Good evening. I'm Psychiatrist Jay Fawver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now in its 26th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call in the Fort Wayne area by dialing 969-2720, or if you're calling long distance, you may dial toll-free at 866-969-2720. Now on a fairly regular basis, we are broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email that I can answer on the air, you may write me via the internet at Matters of the Mind, all one word, at WFWA.org. That's Matters of the Mind at WFWA.org. And let's start tonight's program with an email I received this week. It reads, Dear Dr. Fawver, is religious trauma a recognized condition? I've had trouble finding therapists who understand both my background and safe ways to integrate my current faith. I'm not sure I trust faith-based therapists. Any advice? Well, you're talking about religious trauma, which I believe refers to evil deeds committed by men and or women in the name of God in a religious community. Now, that's something that can cause people to be very traumatized later on because they have trust and faith in these people who are doing their deeds in the name of God, the ultimate authoritarian figure. So it's kind of like being abused by a parent in that regard. You have a lot of trust in these people, and here they are sexually, emotionally, or physically abusing you. And that's the kind of trauma that can lead to have people having post-traumatic stress disorder, where they later on feel very, very anxious and hyper responsive when they get in that kind of environment, and they start having an unwillingness to maintain their faith, and it can significantly impact your relationship with God. So with that in mind, what's the first thing you can do? Try to find people who have had a shared experience as yours, and that's sometimes difficult to do, but try to find people who understand the faith that you were previously, the faith community in which you were previously engaged, and who have endured similar experiences. I don't want to go into details, and I'm not going to mention names of therapists who you could see, but there are therapists and people in particular religious communities who have endured trauma, and they've gone through the type of experiences as you've described. So that's a good start. If you have difficulty with true post-traumatic stress disorder where you're hypervigilant, you're always on edge, you're having nightmares to this day, you're having difficulty with avoidance of people and situations, and it's affecting your relationships with others. That's post-traumatic stress disorder, and that is warranted for particular kinds of individual therapy toward those particular symptoms, as well as certain medications that we will use. But finally, should you go through faith-based therapy? Faith-based therapy would be for the purpose of trying to bring you back to objectify your relationship with God. Don't relate how you are in your relationship with God based on your experience with these particular people who were obviously in a very bad situation, exhibiting evil deeds in the name of God, and that puts them in a position where they're going to be accountable themselves. But for you, it's important that you maintain a good, healthy relationship with God despite what you've gone through in the past. Let's go to our next caller. Hello, Dawn. Welcome to Matters of the Mind. Well, Dawn, you want to know if environment is a big cause of mental health disorder. Dawn, it's estimated that the environment itself is probably anywhere between 30 and 60% related to mental health conditions. For depression, for instance, it's thought to be about 70% the environment. For bipolar disorder, where people have manic depressive conditions, that can be responsible for maybe 40%. Environment can be responsible for about 40% of that condition. For ADHD, that's thought to be about 20% environmental. But there are genetic factors, but the environment goes back to childhood. Now, when I say going back to childhood, we're talking about going back to before 8 years of age. So before 8 years of age, people can be very influenced by sexual, emotional, physical abuse, and your relationship with your parents at that time is a very, very strong, will have a very strong impact on how you relate to others in your life, authoritarian figures as well as interpersonal relationships. So prior to 8 years of age, your brain is very much still growing and you're getting hardwired for how you'll be able to adapt to stress. So yeah, early on we are hardwired with our genetics, but your genetics can be strongly influenced and molded in those very early vulnerable years. And this is why with the previous email, we have to talk about how trauma within a religious community can be so impactful for somebody later on, and how they can trust authoritarian figures and even have a trust in their faith in God. So it's important for us to understand that those early childhood environmental traumas can be a big factor on how we cope with things later on. So as we learn to cope with traumatic situations, that can actually strengthen you over the course of time. People who have never learned how to cope with traumatic experiences can sometimes be crippled with similar traumatic experiences in the future. If you've dealt with experiences in the past, you've overcome them, it gives you confidence and a knowledge of being an awareness of how you're going to be able to respond in the future. So genetics will be a factor, early childhood experiences can be a factor, your ability to cope will be a factor, and then as you go through life, what's happening around you can be somewhat of a factor after you've been hardwired with genetics, with early childhood experiences and early coping experiences. As you go through life, you can have stuff happen. Now, stuff happening means it's a stress. If it's any change in your environment, it's a stress. Now, there are good stresses. We want to have good stresses that keep us strong and keep us alert. We don't want to go through every day where every day would be exactly the same. That would actually make us kind of lackadaisical, and it wouldn't make us very interested and excited about going through life if every single day was the same. So we expect new things to happen day by day, and by definition, that's a stress. The question is the stress overwhelming for you? If the stress is overwhelming for you and cripples you, that's where it can cause you to have clinical symptoms of depression or anxiety, and that's what we'll often treat in the psychiatric field, when somebody's crippled by the disturbance in their mood, their anxiety, due to environmental stresses that are often occurring. Now, as you go through life and you have more episodes of depression and you have ongoing difficulty with anxiety, less stress is necessary to kick you off into another mood or anxiety disturbance. So as you go through life, you'll notice that if you've had difficulty with more of these mood and anxiety disturbances, you're more likely to be vulnerable to stresses in the future. So for that reason, it's important for us to help people cope with stress and cope with changes, and that's the whole concept of psychotherapy. But the underlying treatment from a medication standpoint, from a biological standpoint, is very important as well. And I often describe a scenario where if somebody's driving a car somewhere, if you're driving a car, you're pushing on the accelerator and you're pushing on the brake. The accelerator is like this particular neurotransmitter that's in the gray matter of the brain, the outside part of the brain, glutamate. Glutamate is the accelerator. GABA is the brakes. Now, 70% of GABA is attached to glutamate. So you got brakes attached to your accelerator. So you're getting acceleration in the brain, you're getting braking in the brain. And then you have these three chemicals, serotonin, norepinephrine, and dopamine, which come from the brainstem down here. They project to the outside part of the brain, and you've got the glutamate, which is the accelerator, the GABA is the brakes. Serotonin, norepinephrine, and dopamine are kind of sitting in the passenger seat, giving advice and telling the brain to either speed up or slow down. Serotonin being more prone to telling the brain to calm down a little bit. Dopamine and norepinephrine being more prone to get the brain more fired up. So the neurotransmitter, serotonin, norepinephrine, and dopamine have their roles. And we've been focused on those particular neurotransmitters for the past 6 decades. But now we're talking more about going directly to the gray matter and affecting affecting glutamate and GABA for that matter. So serotonin, dopamine, and norepinephrine are influencing glutamate and GABA, but glutamate and GABA are the accelerator and the brakes respectively. Now, what's the role of therapy? What's the role of the talk therapy itself? The talk therapy is actually helping you steer in the direction of your ultimate navigation. Now, from a navigation standpoint, we all need a purpose. We all need an eventual intention of where we're going in life. We need to be navigated there. The idea of talk therapy or psychotherapy is very important because it is helping you with steering. So when you're in driver's training and you're learning how to drive a vehicle, you're taught how to accelerate, you're taught how to slow things down. You've got the driver's training teacher beside you, or it might be your parent, but they're actually giving you advice on speeding up or slowing down. But very importantly, they're helping you with the steering. They're helping you navigate the particular road and get to where you need to be. And the ultimate goal is what we all need. If you lack purpose and if you lack goals in life, you're more likely to get depressed, and you're more likely to have trouble with just having a sense of purpose. We all need that eventually. But the idea of talk therapy or counseling is to help you with the steering of getting where you want to go. Thanks for your call. Let's go to our next caller. Hello, Shauna. Welcome to Matters of the Mind. Well, Shauna, you had asked, is there an alternative to risperidone? That used to be called Risperdal as a brand name medication. Risperidone is a medication that blocks dopamine and has a lot of other effects as well. But you're mentioning that with risperidone, you're sleepy during the day and you can't sleep at night. Well, in that case, Shauna, it might not be the best medication for you if you're having those kind of troubles. You can always talk it over with your primary care clinician or the prescriber who's giving you the risperidone. But risperidone is a medication that came out in about 1992 or so, 1994. It's been around for about 30 years. And it's a medication that blocks dopamine, but it also has effects on serotonin and to a lesser degree histamine, and it affects various other neurotransmitters. But it's different from the older medications like haloperidol or Haldol, which primarily just block dopamine. But risperidone is used for a lot of things. It's used for psychosis, but it's also used for mood stabilization with bipolar disorder. Sometimes people will use it as a very small dosage as an add-on to help somebody be able to help them with their mood with an antidepressant medication. Risperidone can also be used for something like stuttering. So risperidone has a lot of different features, and it can do a lot of different things. But if it's causing you to be sleepy during the day and you can't sleep at night, yeah, you might not find that it's going to be a good medication for you. Now, if you said you were sleeping at night and you're sleepy during the day, I'd certainly say, just off the top of my head, you could probably benefit from a lower dosage of it. But I take it you're trying to use the risperidone at bedtime to sleep, and you can't sleep at night, but it's causing you to be awake during the day. Now, sometimes risperidone as a side effect will cause something called akathisia. Akathisia is a phenomenon where you have a hard time sitting still. So when I've seen somebody in my office in the past with akathisia, they'd be pacing the whole time and they couldn't sit still. Even with telehealth, where I'm treating people now with telehealth, they're often having a hard time sitting still during the interview, and that's called akathisia. It's a horrible feeling to endure, and it's due to tight dopamine receptor blockade. When you tightly block dopamine receptors, it will cause you to have a hard time sitting still. And sometimes people misinterpret it as anxiety. So what do? They increase the dosage of risperidone or haloperidol or whatever is causing them to be restless and anxious. That's the worst thing you can do, because that'll typically make the akathisia worse. So you have to identify, is it akathisia or is it nervousness from anxiety? Because both can come across as pacing, but with akathisia, people will say they don't feel anxious emotionally, it's just that they can't sit still. And that's a side effect of risperidone. I bring that up because sometimes people will say they can't sleep at nighttime because they're so restless and they have that akathisia phenomenon from the risperidone, and then they're pacing all night, and then because they didn't sleep very well at night, they're sleepy the next day. So there are different reasons why somebody might not be sleeping from risperidone, but yet they're tired the next day. There are so many different medications from which we can choose nowadays, though. Risperidone was one of the first newer medications to come out that didn't just block dopamine. Clozapine was the first one that came out, then risperidone was the next one that came out in the 1990s. Then 1996, we had Zyprexa or olanzapine come out. 1988, we had quetiapine or Seroquel come out. And then we've had other medications since that time. And they work in different ways. So depending on the nature of your problems for which the risperidone is being used, you could try a different type of medication. So talk it over with your prescribing clinician. Shauna, thanks for your call. Let's go to our next caller. Hello, Marianthea. Welcome to Matters of the Mind. Marianthea, you had mentioned the traumatic brain injury. If you have a traumatic brain injury, is it possible that a prescription will not work to treat mental health disorders? It depends with a traumatic brain injury if the traumatic brain injury was the cause of mental health disorders, or if a person already had mental health disorders, then they had a traumatic brain injury. We've seen some people who have endured a COVID infection, quite frankly, and after the COVID infections, their medications for depression or anxiety might not work as well. And we consider that somewhat of a traumatic brain injury. A traumatic brain injury by nature is an injury to the brain where, well, you think about a concussion, for instance, where the brain, having the consistency of jello, kind of bounces around this thick skull of ours and kind of gives you a brain bruise. When you have a brain bruise, you have this exceeding amount of glutamate. I mentioned that earlier, glutamate being the accelerator of the brain. Exceeding amounts of glutamate can cause you to have trouble with irritability, moodiness, and poor concentration. So you don't want too much glutamate in your system. So what do? Well, you give medications that might stabilize glutamate and do so in a different way than the traditional serotonin medication. So we might give an anti-seizure medication like Lamictal or lamotrigine, which stabilizes glutamate following a traumatic brain injury. Now, if somebody's had COVID specifically, and that's why clinicians were often asking, did you feel worse after you experienced COVID? Most people have experienced COVID at some time. So we're asking them, did you feel emotionally and physically and even mentally worse? Did you have more trouble thinking after you experienced COVID? If that was the case, we're thinking about certain medications now that might be more helpful for those kind of symptoms. If you have a lot of trouble with energy and concentration, for instance, we're thinking about using Trintellix or vortioxetine quite a bit. Trintellix has been around for 10 years now, but it's used specifically for depression. But we have an observation that it helps also with speed of processing of information. So it basically improves your internet speed in your brain, and it allows you to think through different things more quickly, and that's something that people are often lacking after they have COVID. If you've had COVID and you have a lot of difficulty with moodiness and anger and irritability, and it's kind of lingering for months by months, we might add on a medication like lamotrigine that stabilizes glutamate. So it depends on what kind of symptoms somebody will have. But we've seen scenarios where somebody has a traumatic brain injury, and they've had a concussion, and thereafter they have trouble with fatigue, poor concentration, they don't enjoy things, they lack motivation, they have trouble with sadness. With those kind of scenarios, we're going to treat the primary problem being the traumatic brain injury first and foremost. If you already have symptoms of depression or anxiety and they didn't do so well following a traumatic brain injury, or they got worse, then we might add on something to more specifically address the after effect of the traumatic brain injury on your underlying mood or anxiety disturbance. Marietta, thank you for the call. Let's go to our next caller. Hello, Tony. Welcome to Matters of the Mind. Tony, you mentioned you suffer from winter depression, and you take duloxetine. You recently heard that you started having ringing in the ears and wondered if that could be a medication side effect. Tony, if you start having ringing in the ears from any medication, even though it might be rare from that medication, it could be from that medication. So I'll often advise people under their clinician supervision to try going off the medication for about 2 weeks and see if the ringing in the ears go away. Now, with ringing in the ears for winter depression, more commonly we hear about that with bupropion or Wellbutrin, Tony. Bupropion or Wellbutrin is used for winter depression. It's primarily affecting dopamine and norepinephrine. It has half of the potency of a stimulant. In that regard. It's not addicting, but it can give you an energizing, activating kind of feeling. But about 1 out of 20 people on bupropion can have a ringing in the ears. It's kind of a buzzing, high-pitched sound, and you go off the bupropion, typically it goes away. It can happen with duloxetine. The good thing is, Tony, there's a lot of other options out there. And even though you have ringing in the ears on duloxetine, also known as Cymbalta, you might not have ringing in the ears with bupropion, keeping in mind that duloxetine and bupropion are entirely different medications. So you could try something else that might decrease the ringing in the ears. But the first question would always be, is the ringing in the ears from the medication? Usually if ringing in the ears is from medications, it's going to be both sides, bilateral. It's going to be on both ears. It's not going to be on just one ear or another. If it's on one ear or another, typically it's from an inner ear problem or something that an ear, nose, and throat clinician would be able to address. Tony, thanks for your call. Let's go to our next caller. Hello, Beth. Welcome to Matters of the Mind. Beth, you want to know if children benefit from seeing healthy relationships, and if so, how can you model that as a single parent? You bet, Beth. I mean, as I'd mentioned before, if you have traumatic experiences prior to the age of 7 or 8 years of age, that's very, very impactful for a child. Children are going to notice how you interact with other people, including other loved ones or former loved ones, in a sense that if you have if you're in a single relation, if you're a single parent and you still have a hostile, angry relationship toward the father of the children, the children are going to pick that up. So you don't want to model that, and you want to be able to suppress whatever anger or irritability you have toward the parent for those children themselves. So the best way to model it is maintain healthy relationships yourself, and try to remember that you're always the parent and they're always watching you. Children have a tremendous ability up to the age of 24 to download new information, and much of that is by observation. The right front part of the brain up here is very good at mirroring behavior. So children are like those little animals you see that are mirroring the behavior of their parents. Children can mirror behaviors of their parents, and they remember that. And that's why you'll often hear about children as they become adults, they take on the traits, sometimes unknowingly, of their parents. And some of those traits they don't want to take on, but they do naturally. Because when you're a child, you will often model behaviors that you've seen as a child, and you go through life and you start to emulate those kind of behaviors because that's where you've learned them. Now, part of the whole idea of therapy, and that's the learning how to drive where you're using the steering wheel, part of the idea of therapy is try to unlearn some of those behaviors and be aware that you've picked up some of those unwanted behaviors from your parent. You want to pick up the good behaviors, but you want to do away with the unwanted behaviors. Beth, thanks for your call. Let's go to our next email. Our next email reads, Dear Dr. Fawver, I've been self-medicating with marijuana for my stress. I've tried counseling and it doesn't seem to do that well. What can I do? Well, marijuana, especially under the age of 24 years of age, will tend to suppress the growth of the white matter of the brain. All over the brain, we have this white matter. White matter is known as myelin. Myelin is basically the insulation for the individual neurons. So you have all these billions of individual neuron branches out there. And under the age of 24 years of age, especially, your brain is still growing. And if you use marijuana before the age of 24 years old, it's very likely that you'll suppress the growth of the white matter of the brain. And that has been shown in some studies to actually decrease your expected IQ as you get older. And there's more recent debate saying that even if you start using marijuana in your middle-age years, your 30s or your 40s, it also seems to have an impact on your ability to think and have reasonable memory. So marijuana, THC, is something that can give you a calming effect. Many people will say it's great for sleep. They'll say it relieves nausea, pain. It does a lot of has lots of nice benefits for people. But if it was to be approved by the Food and Drug Administration today with the same scrutiny as other medications are approved, it probably wouldn't pass. Because when medications are approved by the Food and Drug Administration, not only do they have to be shown to be effective, number two, they have to be shown to be more effective than other things on the market, especially in Europe. They always have active comparators. But number three, how they do with short-term safety issues and long-term safety issues, long-term being at least a year. If marijuana was assessed to that level of scrutiny, I think that the safety issues would probably make it disallowed by the Food and Drug Administration, mainly because of the difficulty with cognition, the slower reaction time, the poor memory, the decreased speed of processing. All these things would be hazards that would probably not allow marijuana to be approved. Now, you can always make the argument, well, alcohol, tobacco, those are dangerous as well. They are, but I think we have to have that discussion when we talk about the use of recreational marijuana. Is it safe or is it not? I think we can clearly say it's not safe for people under 24 years of age. So that would be a motivation for coming off of it. So we have ways to help people get off of it. When we have people get off of marijuana, we'll always ask them, why are you using it? Now, if people are using it just recreationally and they're using it only when they go to different parties, usually it's not a problem for them and they can get off of it if they truly want to. But many, many people will use marijuana because they'll say it's the only thing that helps them with anxiety. Okay, that's a place to start. We can look for other types of medication to help with anxiety. Many people, when they start using marijuana as early as 13 or 14 or 15 years of age, have not learned adequate social skills, because if you use marijuana at 13, 14, 15 years of age, you get to the point where you don't care, and it makes you more apathetic. And you don't learn that normal social anxiety that we all have to learn as adolescents. Going through adolescence should be anxiety provoking. If you're using marijuana during those years, you just don't care. And you go through those years not caring. So I'll often see somebody in their 30s or early 40s who might have the emotional maturity of an adolescent because they never learned the social skills that are necessary to overcome social anxiety that we should have all learned when we were adolescents. So we'll often deal with the reasons why somebody might be using marijuana. If you're using it more for sleep, we might go with a different approach. If you're using marijuana for help with depression, many people will say they feel depressed, so they want to use marijuana for that reason. That will help us decide which direction to go with medication, not addictive medication. We don't want to trade a benzodiazepine for marijuana, so we don't want to give somebody Xanax, Ativan, Valium, Klonopin for the purpose of helping them get off marijuana. We have safer means of getting around that. So I think it all comes down to what the issue is in terms of the reason for why somebody be using marijuana, and then go from there. Getting off of marijuana with heavy use can cause a lot of difficulty with nausea, and people can have extreme anxiety and insomnia as they're coming off marijuana. So we want to be sensitive to that and help people get off of that. Thanks for your Well, let's go. Unfortunately, we're out of time for this evening. If you have any questions that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at wfwa.org. And we are also now available on YouTube in between episodes. I'm Psychiatrist Jay Fawver, and you've been watching Matters of the Mind on PBS Fort Wayne. God willing and PBS willing, I'll be back again next week. Have a good evening. Good night.